First of all, I want to officially welcome everybody to the OB Hospitalist Group presentation today. We've had the pleasure to work with OBHG, and today we do have a slight modification in our speakers. Dr. Simon, who's the medical director for OBHG, is ill today and actually has no voice, as fortune would have it. So he will not be able to speak today. However, on the very positive note, Heather Moore, who is the Director of Risk Management, Quality, and Compliance, who is also co-presenting with Dr. Simon, will carry the ball 100%, and she's still going to be covering all of the content and is fully aware of his role, his perspective, and Heather, I would even venture to say you probably know the exact words that Dr. Simon might use in very specific situations because you guys work so closely together and travel across the country. So I just want to make that note. And so first, I just want to take a moment and introduce myself. I'm Laura Sparkman. I'm the Vice President for Clinical Effectiveness at APS. I've been with the company for coming up on 3 years, and prior to that, I led perinatal safety work at one of the largest health systems in the country for 62 delivery sites and many babies. But today, we have the pleasure of having Heather Moore, who, as I had mentioned, is the Director of Risk Management, Quality, and Compliance. She is a very experienced healthcare professional in healthcare operations. She manages all risk finance operations in portfolio, as well as leading the National Patient Safety and Quality Initiatives for OBHG. I've had the pleasure of interacting with her, and just a delightful person. Heather, welcome. We're really excited to have you today.
Thank you. Thanks for having me.
Absolutely, absolutely. So we're going to go ahead and get started. How this is going to flow is I'm going to go ahead and give a little bit of a background about Advanced Practice Strategies, APS, and Gnosis for OB, which is the topic of our call today. So APS really has two primary solutions around hiring and developing and engaging the best clinicians that you could ask for. The onboarding and nurse retention solution is called Proficiency, and what we're going to focus on for today is Gnosis for OB. And again, if you have any questions, we're going to go into a deeper dive a little bit on Gnosis, but if you have any other questions around hiring, onboarding, please contact us. We'll have a slide at the end, and you could visit our website as well. So what is Gnosis? Gnosis is an assessment-driven education platform that is really changing how doctors and nurses and anybody who's in the labor and delivery team is learning and then improving based on the analytics that are derived out of the learning platform. As you can see in this visual, anywhere you can access the internet, you can access our solutions. So it's very flexible, it's very interactive. How we are unique, how does Gnosis work, is we measure knowledge and judgment, two primary variables, where most education programs measure one variable, which is knowledge. We are able to measure judgment. And we do that through a variety of ways: narrated simulations, script concordance theory, which is where we give you a very dynamic clinical scenario. We tell you what your management plan is, and then you have to decide what is the best answer. And that is compared to a panel of experts. So the closest you are to the expert answer, you get credit for that. So that is one way that we're measuring judgment. So that is a direct path to proficiency. Does your clinical team know the national evidence-based guidelines, and how closely are they managing to that evidence? Because it's assessment-based, it delivers a personalized learning path on what they need. You can actually test out of content, which is very satisfying on the provider side and the nursing side, but you're only getting content that you need in a prioritized way, 2 to 8 minute segments, prioritized in red, yellow, and green. Red, highest priority; green, content you've actually shown proficiency and you've tested out. You earn CME on an every 15-minute basis. And based on the assessment, we're able to measure how your clinicians compare to their peer group nationally. We have some of the largest databases in the country on knowledge and judgment for providers, certified nurse midwives, residents, and nurses. And we measure in the 4 highest risk areas of OB. Our programs are in fetal assessment and monitoring, hypertensive disorders in pregnancy, obstetric hemorrhage, shoulder dystocia. And then we've also developed a very unique supplemental learning tool called Clinical Pearls. They're highly interactive, case-based, 30-minute learning segments that many of our clients are utilizing to supplement additional learning in these 4 high-risk areas. And we'd love to tell you more about them. We are hearing from our clients all the time, very interactive, and they're learning a lot from these new ways to deliver education. So APS, this is just a quick little snapshot of where we are today. We have about 18% of all obstetricians are utilizing Gnosis across the country. That's a pretty big footprint in the country. And we cover 30% of the physicians in California, Oregon, Washington, and Pennsylvania. Again, so think about what that means on the benchmarking capability. It's very significant. And the same for the nurses. It's better than 20% of all labor and delivery nurses in the U.S. So imagine in fetal assessment and monitoring, you're completing that assessment and you're testing your clinicians' knowledge on and judgment on category 2s, category 3s. How do they compare to 18,000 other nurses? Again, so the rigor and the strength of the benchmarking capability is measured to none other. We are in 6 of the largest 10 health systems in the country. That represents over 600 hospitals in the U.S. And we're growing every day. We have over 80,000 completed assessments in our database, again, which speaks to that very robust benchmarking capability. We're able to show and measure learning and improvement. So this is an example of a percentile rank chart that this is automatically generated. Once a clinician completes their assessment, they get this view into how did I score and why is my learning path designed the way that it's designed. This is an example of fetal assessment and monitoring. This is an average score of where the knowledge is and the judgment, and by practice areas. So we're measuring you and testing you on what you need to know, not the nice things to have. You have to be proficient in all of these areas to do well and deliver safe patient care. The NICHD language, category 2, category 3, etc. But again, these gray dots represent the baseline score, and this is after reassessment. So you're seeing the improvement from baseline in the gray diamonds all the way to over here in the 75th to 100 percentile rank to your peers on second assessment. So this is demonstrating learning and improvement, and again, almost compared to 17,000 nurses. So again, want to show you the benchmarking capability. We have some, very quickly, 2 last points I want to make, and then I'm going to hand it over. We're going to get going with Heather. Gnosis helps reduce risk. So we work with a very large, several large clients throughout the country, but one example is Beta Healthcare Group. They've been using this for several years, but they have seen a 55% decrease in claims. The cost of claims is down and the overall claims are down. So that is a huge factor in mitigating risk, particularly in OB, which is a very high-risk clinical area. And then the other component is on the clinical outcome side. We have many examples, but this is one example of one organization, Texas Children's Hospital, has decreased massive transfusion protocols, which I call obstetric hemorrhage codes, by over 40%, or nearly 40%. They're getting ready to publish a paper on their results in their program that included using Gnosis as a foundational component. So we'll be telling you more about that as we get going. So I think the key points I want folks to walk away with is that we are helping organizations realize reduction in risk, and we're helping organizations realize real clinical outcomes, which is the ultimate goal in any education initiative that you launch. You want to be able to have that care, and financial ROI. So with that, Heather, I'm going to hand it off to you.
Sounds great. Well, thanks, Laura, for having me today, and thanks to APS for having OBHG join this call. As Laura mentioned, I'm Heather Moore. I'm with Ob Hospitalist Group. Ob Hospitalist Group, a little bit of information about us here is that we are the largest provider of OB Hospitalist programs nationally. We just celebrated our 10th year anniversary in the industry, and so that was a big milestone for us, particularly if you think about OB Hospitalist as a model and as an industry still being fairly young. And so we are proud that we were some of the pioneers in that space and continue to see a lot of growth and opportunity as we believe the OB Hospitalist model continues to become the standard of care across the industry. So I think that the value of or one thing that we hope to get out of the discussion today is I have a few slides that I'll go through which will kind of tell a little bit about what our story's been, why we believe that a partnership with APS is logical for us, and what we have achieved and hope to continue to achieve from that partnership. Where are the synergies? What's the hope for the future? Where are we all headed toward on this path of high reliability, which I think is the heading of today's title. How do we get there together to these type of logical partnerships, and then try and do that over a course of maybe 15 minutes, and I think that will open it up then for discussion, and happy to share some of our challenges or opportunities or other components that you all would then, I looked at the attendee list, a lot of health systems that I think as health systems and hospitals think about implementing programs like this, a lot of the pragmatic and kind of logistical questions of what works best and how to go about it and what are realistic hopes for rolling that out. So hopefully we have some time to answer some of those, and I'll do my best to share what our experience has been. So as you can see here, like I said, we started in 2006. If you look in this little chart up in the right-hand side of your screen, this is just a snapshot of some of the things that we've done over the past over the past year. So we deliver about 25,000 babies a year. We continue to grow very rapidly, and so we would expect to blow that number away in the next kind of annual calculation. We have one of the big areas where we focus on is high risk and emergent interventions through the OBED, as well as supporting community providers, the primary ER, as well as managing and having all indigent or unassigned patients assigned to us as their primary provider coming into the hospital. So you can see we have close to, I think right now we're over almost in 500 hospitalists. We're in over 100 facilities nationally. We span 27 states, and so our footprint is quite large. Nationally, we go from Florida to Alaska, and so we're very proud of that and looking to continue to grow and seeing, again, like I mentioned, the industry just believing that this is definitely the way of the future and elevating women's health care. You know, for us, we had a relationship, I'll caveat, we had a relationship with APS for a couple of years before Gnosis was really implemented, then discontinued that relationship. But when Gnosis really came back and we started to, our Gnosis was launched, and we saw what really just absolutely impressive stuff was being shown by Gnosis in the data, because I think without data, all of us don't really know where to move forward in different initiatives, especially in this world of quality and risk, without having meaningful data. And so for us, it became an absolutely logical partner, a leader in OB education, with us trying to lead some movements in women's care. And so for us, that really just created a logical move for us for the relationship that we relaunched with them in the beginning of 2016, and we've been very happy about how that relationship has gone so far. And we'll share with you some of those findings. Okay, I'll spend a couple minutes talking about the model, because I think the OB Hospitalist model, for those of you that aren't familiar with it, or the OBHG model, will be of interest. So, you know, one of the early ways that we recognize a real an issue in the traditional care model versus what an OBED or an OBHG program would do would be the creation of an OBED. So in a traditional model, patients who, and I think this really can vary depending on how a hospital views this between 14 to 20 weeks. So it's just using generically 20 weeks. A patient who is under 20 weeks goes and is seen in the main ED. After 20 weeks, that patient is considered to, quote, high risk to be seen in the main ED, and then goes instead to the triage, and at that time could kind of be seen by just a variety of situations, nurse triage led primarily, phone triage to ultimately determine what is the patient who's going to be discharged, the patient who's going to be admitted, presents quite amount of time and delays of care, and really just not the bottom line, and not being a team-led holistic approach to decrease delays in care of patients being seen, and ultimately a patient presenting pregnant, an emergency medical condition, being able to be discharged from the hospital without ever being seen by a provider, which was something unique for a pregnant patient, and was something that just was part of an archaic system that continues today that our founder, Dr. Chris Swain, just said is absolutely something that we can't continue to allow in our healthcare system. By creating the OBED model, patients who are past a certain week and are no longer seen in the main ED, and I'll just caveat and say that we also have opportunities to go see patients in the ED as well, or help manage those patients, for example, an ectopic pregnancy as such. But patients who are over certain weeks instead come up to the OBED. So it's the triage which is transferred into a true OBED. It is a team-led approach, as it should be, with physicians and nurses. It creates an environment for very effective, timely assessment of the patient that's presenting, making sure that the correct assessment is made for potential admission or discharge, provides consistency in the continuum of care. We believe it's a huge patient satisfaction increaser. And also from my world and the risk world, we believe that it is a huge risk mitigator and risk savings opportunity as well for the hospital and the providers. And so I think that model is just important to kind of call out as one of the main distinctive components or kind of foundational components that creates, separates an OB hospitalist model, we would call a true model, from what you might hear as just a laborist or a staffing model elsewhere. So just wanted to spend a couple moments on that. Okay. So one of the things I mentioned before about the OBED and the model, but I think that in the very beginning we thought, and I'll just share this, 10 years ago, we thought, man, if we can create the OBED and we create a better continuum of care, we're going to have better outcomes, and that's going to be fantastic. And I think the idea of what was that also going to do to our risk for our providers as well as the hospitals, really didn't understand that at that point. We were certainly new to the industry, and as we've gone through that exercise, what we found has been over the years a really impressive data set as it relates to what our risk impact has been, not only for us as an organization, but also the risk that has then been positively impacted at the hospitals as well. So if you look here, just I would like to share this chart, this is some current 2016 data. If you follow this left to right, you can see that most of claims, somewhere between 30 to 40%, depending I think on what data set you look at, generally involves OB claims delaying care of fetal distress. That's one of the most common OB allegations. As I mentioned earlier, we have a very high percentage, roughly between 30 to 40% of our encounters are high risk, and we operate in some very interesting jurisdictions from a risk perspective as well across the country. If you look at frequency and severity of claims, so frequency of claims, 10% of OBs still tend to get named annually in a claim, and our data has ranged between 1 to 3% of OBs nationally, which is very, very favorable. And then if you also look at births that result in indemnity, some sort of payment out, Berkeley Med last year released that 1 in every 4,600, and that's actually been since updated to 1 in every 3,700 births nationally have a case with indemnity, and our data is 1 every 20,000, and then that actual numbers behind that is pretty significant difference as well. And so for us, this is a huge part of the value proposition of what we provide our clients, is the promise of and the hope of improved outcomes and decreased risk. And if you are adopting a OB Hospitalist program to achieve those two things, then I think you are achieving some really good things in your women's healthcare arena. But for us, it was, how are we going to continue to raise the bar even more? How do we make sure that this data, as we grow, as we go from 20 to 30 to 40 states, how do we make sure that we have the data that tells us where our real risks are and how to tap into potentially risks that we're not seeing or we have a blind eye to? And for us, that's really where APS starts to come in from the risk perspective, is how do we get more data to understand where our weaknesses are, so that this, if it doesn't deteriorate, if anything, this positive data continues to just get better with time. And so part of that is incorporating for us APS into a holistic approach to our SAFE program. So our SAFE program is OBHG's risk management and quality program that is implemented into every single one of our program sites. All of our providers, our physicians and certified nurse midwives are trained on SAFE, as well as our hospital partners and administration and those that work most closely with our program. And there's a variety of different components of SAFE. I won't go into all of them. As you can see, we call these sections different pillars or different offerings within the SAFE program that we believe together ultimately track quality, improve processes, result in improved outcomes, and ultimately reduce risk and reduce claims. We feel fortunate and believe that we have the largest risk database out there for OB hospitalists. For anyone who knows a lot about the OB hospitalist data set, most of it gets lumped in still with OBGYN, kind of a private practice data, and that is very different than OB hospitalist data. And so we believe we have one of the largest databases there, which allows our clients to cross and look across, 100 other partners regionally, nationally, to understand how their performance is to some of their peers. And the main thing here for purpose of this conversation is that we have a platform of OBHG University for which APS is a logical partner for us as part of our education platform. So all of our providers are required to take their fetal monitoring assessment as part of Gnosis prior to their first shift with us, and are then monitored through members on my team for their completion, their learning paths through Gnosis. So Gnosis is actually built into our employment agreements with all of our providers, and it is something that they are trained on, and we set very high levels of provider engagement early on in the process, understanding that APS and our commitment to education and Gnosis is absolutely is paramount, and that's something that we will monitor and be heavily involved in throughout their duration of their employment with OBHG. We're seeing a big movement of hospitals, I think, tying Gnosis to some credentialing process. Many of our partners are doing that, and we, as a large hospitalist group, have the opportunity to tie it as part of our employment relationship with our providers, and we take that very seriously. Okay, so now we'll spend a little bit of time. I just have a couple of slides where we'll talk about the actual meat of some of what our data is saying. Because I think this just gives you an example. If you don't know what kind of data you get back, I think a lot of times you always hear when you're looking at a new platform or you're looking at a new opportunity, you always hear of all the amazing data that you're going to get. One thing that I can say about APS is you actually then get some data. So we are very still early on in our process, in that we launched this in the beginning of 2016, as you can imagine, with almost 500 providers in different kind of phases of continuing education from previous systems or hospital systems. Converting everybody took quite a bit of time, and so we're still in that process. But even so, I'll kind of call out that all the next three slides are really all part of what we would call the baseline or benchmarking data set and some additional data finds. One of the most exciting things we found right away for the group of providers that had already completed their first assessments and learning paths was that they had saved on average of essentially 5 hours on coursework that they would have had to take in kind of a traditional course format, or what I think we call the kind of roll and scroll format. And again, it's the idea of taking bite-sized learning, so they go through the assessment and they understand, okay, here's what our weakness is. I need to spend more time on category 2. All right, my learning path is going to spend a lot of time focusing on what I need to know, as opposed to just repetitive things that I already know and don't really need to learn again at this time. I think that speaks to, adult learning and how that functions best. There's a couple other, I think, kind of pragmatic points that as a client I want to point out here. One is for hospitals, or depending on where you are in the country, this is time that you are potentially not having to pay for your staff then to take coursework that they don't need. So these are actual hours of pay stays. And I think if you add that up by provider, certainly if we look at that, it starts to become a pretty meaningful number in terms of subsidizing payment for the program itself. And then the other thing is, we believe that by having work that is really concentrated to their highest need level, they're also going to be more open to looking at some of the other material we want them to look at. So for example, I mentioned our OBH University platform. We have a lot of information in there and resources and best practice and webinars that are really geared specifically to your role as an OB hospitalist. And while we don't mandate attendance for every single one of those learning opportunities, we do believe that if they have a more concise and effective learning path with Gnosis, they're more likely to carve out some time to tap into some of those other resources that we really want them to as well. And so this is a very big win for us, and we think that it's something that most of APS's other clients are seeing as well.
Yeah, Heather, so I'll just jump in here real quick. I think, so if folks are wondering, like, excuse me, what does this 8-hour, 15-minute represent? This is like a traditional course, and it was actually our original long-form course before the Gnosis kind of assessment-driven learning platform. And the experience that OBHG is having on the provider side for electronic fetal monitoring, fetal assessment and monitoring program, this is very typical to the experience we see in our database on average for all providers. So they get credit, CE credit for the assessment time and for the learning path time. So keep in mind, if you think back to the model, you can also imagine those learning segments are in 2 to 8 minute chunks. Do you have any sense, Heather, how your providers are working through their learning path? Do they sit down at all one time? Do you have a time frame that you require them to complete their assessments and learning path?
Yes, we do have a time frame, and I'll say I probably should have Nikki here to say what our requirement is for the first year. So yes, we do have some time frames. Now I think that that they tend, just by nature of being hospitalists and kind of being really on call in the hospital constantly for everything that they might be seeing between the OBED and L&D, I would imagine that a lot of them are taking snippets at a time. The other thing that you mentioned, which I think is very user-friendly for us, is that all of our OB hospitalists have iPads in the call room, and so because there's it's so user-friendly to be able to use on mobile devices or iPads, etc., we think they're taking advantage of that as well when they have some downtime. Okay, so this next slide I want to show you, the other thing I think is really helpful, again, this is just some benchmarking data. So this is what I think is really nice, and I have been pleasantly surprised about with APS, is that I haven't had to wait, or we have not had to wait a whole year for data to come in and to get analyzed and to figure out, okay, now what do we do? We have to come up with this big, perfect plan. Rather, some data has come in already from just a very simple kind of baseline, hey, here's some stuff going on. So in the realm of fetal assessment and monitoring, for the providers who have taken it so far, we have just kind of generically gotten some rankings back that have said, okay, from your highest need to lowest need on kind of the aggregate, here's what we're seeing. And so I think that none of this is particularly surprising. I think that this is probably pretty consistent as well with some other clients, is the kind of dreaded the nomenclature interpretation piece, how are we all speaking the same language, the need to focus on Category 3 a little more heavily maybe than Category 2. And so what this does for us is it says, okay, we can go ahead and be proactive in developing some other supportive materials while all of our clinicians are going through their own individualized learning path. So for example, my quality team is able to say, okay, what can we take from this based on the rankings of need level to help us prioritize a webinar that we ourselves might want to go ahead and put up proactively around fetal monitoring? Well, this helps us know where we might or might not want to focus on first. And so this kind of feedback is just really valuable to just get a sense, again, in the aggregate of how people are trending, and then also to be able to say, okay, 6 months from now, once you see many people who have completed their learning path and are further along in the program, does this change? And does this start to look different? And where have been the opportunities for most improvement? And again, I think that data is everything. Without data, we can't measure. We don't know where to go without good data. And so getting the data back is really meaningful for us to help build out our OBHG platform and know how to prioritize some different learning paths that we want to go down in that arena.
That's great, Heather, because you're speaking our language, and so this will probably be my epitaph at some point in time, which is you can't improve what you don't measure, right? And so that's really been the value equation with Gnosis. I think what's interesting here in your list of prioritized content areas is Category 3. I'm sure if Dr. Simon had his voice today, this is something I know he would be talking about because we've chatted about it before, but there's a false sense of security across the country, whether it's nurse, midwife, provider, physician, that everybody knows what to do with a Category 3. Everybody can recognize those ominous strips and they know what to do, but our data in our database is telling us something quite different, and that's very concerning, especially if you're a physician nurse leader, because you're seeing these strips. These are the strips that are most highly correlated to fetal acidemia and fetal harm, and so if you have big variation among your providers in identifying Category 3s and then having a standardized management approach, especially in the OBHG model, right? This is the experts. I always talk about, the providers in OBHG. They have a very big job and a very focused job, and that's to do safe deliveries at the hospital. So reducing variation and having that standardized understanding of the national evidence and practice is, paramount to your success and the a safe delivery. So I know that that's top of mind for you, all your providers, and Dr. Simon.
Absolutely. Great. Okay, so the final slide that we wanted to show from some OBHG specific data is, again, just a benchmarking data, baseline data from some of our providers who have already taken the obstetrical hemorrhage course. So what I find about this is just, really, really interesting here is that every single green dot is an actual individual provider. So, we are able to, and you can customize, of course, who should have visibility to this, who shouldn't have visibility to this, all those kind of pieces. But each green dot, you can actually pop up individual provider, where their hospital is, and see what their score was. So you can, and then the black triangle is actually our organizational average for all the providers that have taken it across the judgment and knowledge axes to say, okay, how is the group doing as a whole from a benchmarking or a baseline standpoint, and then obviously paying attention to where clearly this variation, there's more variation than we would like. So how do we go about, again, knowing the data, not just in a vacuum, but understanding the data in a more holistic way, and then watching as this data changes, because I think the benchmark is great, but it really only becomes meaningful if you look at it after people have done their learning path to say, okay, did people change? Because then I would say if you've got someone in the lower quadrant, they're still in the lower quadrant, okay, how do we create opportunities for that person to move up, and how do we do that? The other thing that I use as an example that I'll use here is that there are some situations where I've realized that this kind of data on an aggregated basis or by hospital basis can be extremely valuable. APS, you can customize it. We look at it by regions. One reason we do that is we thought, okay, hey, maybe there's some really healthy competition between regions, so not calling out, hey, Dr. Smith, why aren't you doing well here, but really as opposed to a much more energizing competition to say, okay, our Southwest team is doing fabulous. Their average score across those 70 providers is blank. Let's continue all trying to raise the bar and where are they. So are there opportunities to create some incentives, some healthy competition amongst providers around that? The other thing that, and we also capture at the hospital level. So the other thing that we've started to think about is from, again, back to the risk and claims world, is if we have a hospital that we know, and the example that I use is a couple of facilities that we have programs that really struggle in having just a very unique patient profile that creates an extremely high incidence of shoulder dystocia. So much above the national norm. And so while we might, as hospitalists, being called in sometimes in the 11th hour, not be able to control the incident level or the frequency, what we can control is the management. And so I think what's really interesting, for instance, with that data is starting to drill in and say, hey, how are my teams performing that are in, how are my teams performing in a high-risk area that also matches a high-risk venue? Because those are the teams that we want to be absolutely in the upper right quadrant, rocking it, having no issues, because they're seeing it the most, they're managing the most, they're being challenged with it the most. And so I think just, I use a couple of those different examples of all the ways that you can use data like this. You can use it on an individualized basis if you choose to. You can use it in the aggregate. You can use it as a tool for physician engagement, positive encouragement, energizing, healthy competition. You can use it to really fine-tune regions or hospitals or teams within a hospital that need to really make sure that they're absolutely performing above average just because of the nature of what they're doing or the risk profile that they're seeing in a certain women's center. All of that stuff is just data that is so robust that you can get that. For us, we haven't been able to get that kind of data from an educational perspective anywhere other than some of the data we're starting to see through Gnosis. And so really looking forward to the future and how we're going to be able to continue to use this data to continue facilitating what our goal is in the industry.
That's great, Heather. So just a couple of comments here. I just want to just clarify for those listening today. So this is a standard report that is readily available as soon as clinicians complete their assessments. So these are, as Heather said, baseline assessment scores for the obstetric hemorrhage program. And again, on the X and Y axis, we're measuring two variables, judgment and knowledge, and the blue lines represent the national percentile rank for those in the database. Okay, so all the green dots, as she says, represents the 130 providers that have taken this course, and the black triangle is the organization average, which is above the APS national average. You can see over here they're at the 86th percentile in judgment score and the 63rd in knowledge, which is not surprising, because what typically happens is physicians who've been doing this, they're trained, they know what to do, but there's just variation in the national evidence. And then, new guidelines came out almost 2 years ago around quantification of blood loss. And so how are we assured that we know our providers are on top of and astute with the latest and the greatest evidence? And this is one way you're able to capture that in time. And again, I think as I look at this data, high scores, a few outliers, and it's a great opportunity to say, where's our variation? Even though we have high scores, where's the variation, and where can we reduce variation? Which, again, in the OB world, variation equals risk. So that's an opportunity to, again, improve, not, judge. It's not about that. It's about improving scores and improving proficiency and improving outcomes. So Thanks, Heather. A couple of questions have come in. One, just very quickly, I'm going to ask because you were just talking about the type of education. Someone typed in, they thought that you were using another program, the Sullivan Group for FAM. When did that change?
Yes, that is correct. So in the very beginning, I mentioned that we had a partnership with APS pre-Gnosis, and then we were with the Sullivan Group for, I believe, almost 3 years. Don't hold me to that exactly, somewhere between 2 and 3 years. Great partners, really great people to work with. Ultimately, though, when we reevaluated and basically just said, hey, we want to take the OB education to the next level, the ability for data analytics was something we needed because we wanted to continue to lead the industry, and we needed the data analytics to be able to do it, in addition to thinking the content to being superior. And so spent a lot of time thinking about that, and we in reevaluating the relationship with APS, and so we switched over effective 1/1/2016. As you can see, if you just have been paying attention to some of the numbers of providers who had recently completed Sullivan Group work, we are in the process of still shifting people over. So we did not want to make undue burden for people who were changing platforms too quickly. So we have been sensitive about that, but we have moved over 1/1/2016 with APS.
That's great. And the other thing I'm thinking about is if you could channel Dr. Simon, what do you think when he sees this data, or when he's focusing in on assuring safe deliveries to your clients, what is top of mind, as you guys think about education, reducing variation, and standardization? It's kind of like what's the culture and kind of the mantra that you guys, when you're talking to your clients, what do you guys talk about?
Oh gosh, well I don't know that he wants me to be talking for him, so he might all of a sudden find his voice and try and get off mute here. But on the call, so one of my favorite things that I hear him say, which I think is really, you think about culture of who an OB hospitalist is being someone who is situationally aware on the floor at all times. So we are the person who is there to even if it's not our patient, to be helping the nurses, giving a second opinion if we need to over on a strip, being able to know that if a private physician's in the OR with something else that we might need to step in, getting a good sense of what's going on in the OBED at all time, even knowing what's going on in the main ER, patients that we might need to go see down there, any trauma patients. So the culture is really one of being ready for anything at all times. And we, as I mentioned, with the percentage of high risk that we see, the fact that we get 100% of the unassigned patients, one thing I didn't mention early on, which I think is a huge component of the model, is the fact that it's there's no competition within the model. We don't have private practices. We have no mechanism for private practices. We're 100% in-house, 24/7 with no private practices, and so are private patients. And so that allows for us, we are there to take anything that comes our way. And because of that, I would say you have to be the best. So, we're not able to determine what kind of patient that we're going to have come through the door. And we see a lot of variation in the patient population, certainly, of where we are. And the community providers and the nurses are there and depend on us to know that we have their back and we're there to support them, and that we're there to ensure that there are healthy babies that are born in that hospital, and that emergencies, whether there's a baby involved or not, and the GYN or with moms are safely managed. And so what I would say from a culture standpoint is that's what we're aiming to achieve.
That's great. And I think it's embedded in there too. Part of your answer there is, if there is no pushback, right, around physicians, whether they're going to do education or not. That's part of the culture and the model for OBHG, correct?
It is. So physician engagement, any kind of education, I think it's all about the way you present it. So for us, it is absolutely a culture of, if you're joining the OB Hospitalist kind of platform and movement, it's because you are recognizing, or you want to be part of an industry that truly is changing the future of women's health care. And so the other thing is that we set very fair and clear expectations up front. That quality and safety and the commitment for our providers with our SAFE program happens very, very early, and in their onboarding and even recruiting process. And so I think the expectations are set. They're set fairly. It's part of a culture that a lot of providers who are wanting to go to the OB hospitalist space are looking for anyway. And I think that, all of us want to be the best that we can be in our jobs. I think there are very few people, whether you're a clinician or not, that don't want to be good in your job. And so if you give people tools to say, we're going to show you, not just we're going to do this and you're going to get a certificate and it's going to have no meaning of really how you did, but we're going to give you feedback and tools to show you where you're weak, where your opportunities are, where you're awesome. That feedback, I think, is what drives a lot of people to want to continue to outperform, to want to get better, regardless of specialty, regardless of industry at all. I think that's just how we function. And so that goes a long way, I think, into getting the provider engagement and buy-in as part of this, and knowing the right combination, I think, of stick and carrot, and probably more carrot than stick.
That's great. Yeah, and again, I just, on the APS Gnosis side, that's a common question we get all the time, which is, how are others getting physicians to the table? Do you require them? It's just part of how you do work. And so that's what you're speaking to. But you can see that in the OB hospitalist model, that, it's just part of the way they do their work. It's required. You have to have a certain level of proficiency and performance and score to get an assignment. And then that's something that you manage and model ongoing, and the education doesn't stop. So one last question, I think that came in, and I'll speak to it a little bit too, but it's basically around, do health systems who use Gnosis correlate clinical outcomes to proficiency improvement? And we have the capability to do that. We are now, because of the size of the database, for example, we're able to take scores in shoulder dystocia by peer group or by hospital average and aggregate physician and nurse score. And we're able to say a brachial plexus injury, hospitals that have higher brachial plexus injury rates tend to have lower scores in the program. So there's a little bit, actually not a little bit, but a direct statistical correlation to those low-scoring hospitals and higher injury rates. So it can be utilized as a predictive model for hospitals that haven't yet had BPI rates or at that same, highest level of BPI rates, an opportunity to go in and be proactive to curtail, that event reaching a patient and actually having an adverse event. So I wanted to answer that question. And then we already answered the question. A question came in around requiring physicians to use the program. You already answered that. And I think that's it for the questions. Any other final comments that you might have, Heather, for anybody who is looking to, who would be interested in an OBHG model? How might they, go forward?
Oh, absolutely. So you can, you can reach out to me. I don't know if my information is anywhere on this WebEx or a copy of this. Heather Moore at Hmoore, HMOORE at obhg.com is my email address. Anyone's welcome to email me at any time. Our website is obhg.com. You're more than welcome to reach out to me directly. I'll answer any questions that I can, and if I can, I'll pass you on to the right person. And Laura, I appreciate you hosting today and having us, and I hope it was helpful for people who are on the phone looking into the Gnosis model.